Here, why don't you guys scan the QR codes to us to activate the questions or click on the link in the group. So just to answer them, like, I know you guys are smart. Still on the first question.
It's always C.
Always C.
It's always C.
Huh?
The answer is always C.
Okay.
I did that on the answer.
What?
I did that on the answer.
So yeah, there was a study which showed if you just click C, at least you will pass.
Yeah.
There was a study done that
It's not true.
if there are
Step one.
If- if there are only 4 choices for all questions, if the questions are more than 100, and if you only choose C, there is a good probability you will pass the exam.
Yeah, I think about it every time the answer is not C.
Good reason.
You could be here. Texted immediately to say, yeah.
What?
It's okay.
Shaker told him, texted him last night also.
It's not 7:05 yet. Why? Why? Is he scared?
Because he doesn't feel confident.
No, I don't think that's it.
Should I get started? And we have some people. Mr. Shaker, I texted him, he said he will. Whatever. Anyways, while we are here, why don't you scan the QR code or click on the link which we send in the group. So today's topic of discussion is mitral regurgitation diagnosis and management. Okay. First of all, a mitral valve, don't think of mitral valve as just 2 leaflets coacting with each other. Okay. Mitral valve, this is the very famous figure in New England Journal of Medicine almost 25 years ago, which describes mitral valve functionally as mitral valve apparatus, which includes the annulus, which is surrounding the leaflets, which are 2 anterior and posterior, the chordae, which are primary, secondary, and tertiary. Going from the leaflets down to the ventricle, they will be first primary, then secondary, then tertiary. We will have papillary muscles, 2 of them in majority of the patients, more than 95% of the patients. And in a sense, consider ventricular function, not the structure, the ventricular function and the geometry as a part of functional mitral valve apparatus. Why? Because any alteration in the shape of the ventricle or any regional wall motion in the ventricular wall or any dilatation of the ventricle, that's going to badly affect the function of the mitral valve. So mitral valve would be a collateral damage to anything that happens to the ventricle, and in some cases atria also, but we have included annulus as the apparatus for that. So the function of the mitral valve is the function of mitral valve is very much dependent on the function of the ventricle. So I advise every one of you, whenever you have time, why don't you go to to the University of Minnesota Human Atlas website and see how they have various models of how these valves function in actual human, in actual human beings. And it's a very good way of knowing that these things that we treat it daily on a day-to-day basis. It's good to know how they actually look, what is their interaction or what is the relationship with surrounding structures, to know how we can treat them better. So can someone tell me what pathology do you see here in the figure on the bottom of the screen? Michael?
Well, I'm guessing it's regurgitation, seeing as it's not coapting at all.
Yeah, so you have mitral regurgitation, but at the same time, you also see aortic regurgitation, that the aortic valve is also not completely closing as opposed to in this figure where it was completely closing. So it's a nice way of seeing in live or in reality how these valves function. So just go to the website if you have chance once. So now we'll start with the first question. If you haven't scanned the QR code, if you haven't clicked on the link, just click on the link and get me the answer in next 5 seconds. Where are the papillary muscles located on your mobile screen? You will have it in a much bigger way. 10 seconds to answer this question. Where are the papillary muscles located? If you haven't scanned the QR code, you can scan it here or click on the link in the group. Is it A, B, or C? Are the papillary muscles like this, or like this? No, shit, I haven't done the responses. I'm sorry, I have to see the responses here. Give me 1 second. I should have checked this, sorry. All right, so 50% of you are saying that it is B and 50% of you are saying it is C. All right, so before I get to the answer to that question, let's just look at how it looks. What's the relation of mitral valve with the surrounding structures? So this is the mitral valve. So from lateral to medial, there will be anterior leaflet and posterior leaflet, and there will be A1, A2, A3, P1, P2, P3 from anterior to posterior. From lateral to medial, sorry. Anterior to the mitral valve, there will be aortic valve, and posterior to that, there will be coronary sinus. So if you see a coronary sinus, you can expect that you are seeing A3, P3 scallop. And just on the side of the A1, P1, there will be the left atrial appendage. So the correct answer to this question is B. Why is it important is, keep this in mind, the chordae tendineae never crosses the midline. They stay on the side on which they are. So if it is the anterolateral, if this is the anterolateral, which is below this part, a papillary muscle, it will only supply A1, P1, and a part of A2, P2. If it is posterior medial, it will only supply P3, A3, P3, and a part of A2, P2. The reason why that is important is when we see a pathology, when we see some prolapse, and if it's only single prolapse of A1 or single prolapse of P1, we know that the chordae tendineae of that part is ruptured or broken. Or if it's a flail, if it's a prolapse, then we can see it is dilated. Let's say if the papillary muscle, the anterolateral papillary muscle, because of STEMI, because of infarction, has been destroyed or it's gone. So you will have the entire prolapse and flail of this entire segment from A1, A2, and half of P1 and P2. But this part will remain intact because this structure is intact. So that is very important. This relationship is very important. It is so important. This was asked in the ASC exam this year, if Jan can vouch for that. So this
perhaps you always say like a secondary chordae.
Yeah, you have to.
That you define that this is not the single papillary muscle is giving the chordae to the one leaflet.
Yeah,
and this is giving to the other leaflet.
Yeah, and the other thing is both papillary muscles supply both the leaflet. That is important. And the third thing is when we are doing a mitral clip, keep this in mind. Below A1, P1 and below A3, P3, there is a big jungle. So it's technically not impossible. It is technically limited or technically difficult to put a clip in A1, P1 and A3, P3 region. But look at between A2, P2. Below these leaflets, there is nothing. It's like a full open ground. So it's easy to put a clip in those in this A2, P2 region. So these relationships are very much important. So coming to the next question. If you cannot see the question, the swipe down from the screen, you will have the next question. So this is a 63-year-old male with ischemic cardiomyopathy. He presents with worsening dyspnea. His LV is moderately dilated with an EF of 30%. The mitral valve looks structurally normal, but there is a posterior leaflet restricted systolic motion. How will you classify this MR? Type 1, 2, 3A or 3B. Just swipe down from the screen from the previous question if you haven't, So if you want to see the question better, this is the question here. Nobody has answered the question yet. Okay. So most of you are saying it's type 2 MR, some of you are saying type 3 MR. Now, the thing is, this is going to be a most important, a very important thing for us to discuss. The reason why is the management depends on the type of MR. So this is the ASC to 2018 or 2017 guidelines for mitral valve regurgitation, but it classifies mitral valve into type 1, 2, and 3. Type 1 is whatever the expected motion of the mitral valve leaflet is. If the leaflet has to go like this, they will go like this. They would be moving as expected. Type 2 is an excessive leaflet motion where there can be either a prolapse or a flail where the leaflets are moving more than as expected. And type 3 is restricted motion of the leaflets where the leaflets are moving less than what they should be moving, so less than expected. Now, on a transthoracic echo for ASC guidelines, this is more than enough. But we know that just looking at this thing is not enough in treating the patient. The management depends on much more than just these three types. So that's why in 2018, ACC came up with the guidelines where they classified the Carpentier type 1, 2, 3, and 3B further into primary and secondary MR. So primary is involvement of the mitral valve leaflets itself. If there is a primary pathology in the mitral valve leaflets itself, then it is called as a primary, and secondary is what I talked in the first slide, the collateral damage. If there is some change in the ventricle or the atria, and that leads to MR, then it is called as a secondary MR, or in other words, called as a functional MR. Now, why is this important is because the management, I'll come to the management side where we'll come to know the management differs completely based on what kind of MR we have. Now, most of our patients which we'll have will be secondary or functional MR. Why? Because that is more we are diagnosing them down the line much more, and almost more than 60 to 70% of patients will have that. Keep this in mind. Type 1 will be normal or expected motion of these leaflets. So you will have most likely the annular dilatation in this if it's type 1, and you will have mostly a central jet. But it is a misnomer, or it is a misunderstanding that function has to be central. Functional MR can also be eccentric, especially ischemic cardiomyopathy with regional wall motion and scarring. I'm going to explain the importance of that down the line. But keep this in mind. You have to classify as type 1, type 2, type 3, and primary or secondary MR. This is the 2025, just 2 months ago, the new guidelines came how to further classify secondary or functional MR into atrial and ventricular MR. So there are some salient features which we need to keep in mind. For an atrial MR, there will be dilatation of the atria that will lead to secondary dilatation of the annulus, and mostly you will have a central jet. So patients might have atrial fibrillation most commonly, and some HFpEF, but mostly atrial fibrillation or condition in which there will be atrial dilatation. These people will have annular dilatation and MR. The EF has to be more than 50%. The LAVI obviously has to be more than 34. That is the criteria for left atrial enlargement. And the annulus has to be more than 35 centimeter, 3.5 centimeter. So if you have EF less than 50%, you cannot label it as atrial. You have to label it either as mixed or ventricular MR. Not so. You need to have an EF more than 50% to have an isolated atrial, and the LAVI more and annulus dilated, and patients with with atrial fibrillation. In contrast to that, a ventricular MR is somebody who has an EF of less than 50% for sure, may or may not have regional wall motion, that's fine. But there is something very peculiar for ventricular MR. There is restricted leaflet motion with tethering. I'm going to show you the slide of what that means. If you see this kind of movement of mitral valve in systole, like the way the mitral valve is moving, if you see that peculiar characteristic sign, that means you can easily label that this is a ventricular MR or mixed MR with a ventricular component in it. So this is the most important part. And of course, the patients will have ischemic cardiomyopathy, which will lead to regional wall motion or something like that. So just to revise of what we learned till now, we might have a primary pathology of the mitral valve leaflet, which is a mitral valve prolapse. As in this case, the P2 is prolapse. We're looking from the atrium into the ventricle on the 3D view. Or you can have a rupture of chordae. This is a single chordae which is ruptured, which is of the P2 only. On in other, you can have a primary ventricular MR. I'm going to explain you the specific the motion of this one. Or you can have a mix where you can have a part of ventricular or a part of primary MR and a part of secondary MR, both combined in a patient. So this is this discussion. So I'm going to give you only the exaggerated or very easy things to see. This is clearly a case where the posterior leaflet is moving much more than expected. It is moving all the way over here where it should be stopping over here. And because of that reason, you can see that the MR is eccentric. It is going to the opposite side. And this is clearly a case of type 1, 2, or 3. Which one? Excess leaflet motion. Is it type 1, 2, or 3? 2. Type 2. Primary or secondary? Affecting the leaflet itself, or is the leaflet is secondary to something? Primary, because it's a leaflet or the main apparatus which is affected. So it's written
One
primary.
point here, a lot of times you will see these patients that come with severe MR with the clear leaflet. And you saw, you're like console cardiothoracic surgery and you're young, you want to, but just take a look back. Just because you diagnosed it does not mean that the patient need to be optimized first. So we had recently a case where I transferred this guy from uni. If you look at the left atrium enlarged, EF is a little bit down. This MR has been going on for a while. These patients you send in from open heart surgery. If the surgeon is not feeling comfortable with the minimal invasive repair, don't rush into getting them into surgery until you believe. Give them a couple of weeks. If they have AFib, it's going to be hard to treat AFib because there's a lot of jet. But whatever you have to do, put an amnio, get them on the GDMT, let them optimize. Don't rush into this knee-jerk reaction. You found the severe MR. If it's acute papillary muscle rupture, pulmonary edema, those are whole different problems. I'm talking about somebody who walk in the ER for a couple of months. You look at that LAVI is like 50s. You saw the pathology. Don't rush. Optimize them. Give the surgeon a very good classification. What do you want the surgeon to do? You should not ask the surgeon what you should do. You should tell the surgeon, this is the etiology, this is what we're expecting, and this is, so that patient, I think was one of you guys had it, he was in AFib. We actually cardioverted him and we discharged him to have like a 4 to 6 week follow-up and go.
And that we'll discuss that as we go for the management part. So this is functional MR. Now this is the most important part because this is the most common we see over there. So what happens? This is let's focus only on the posterior medial papillary muscle right now only. Let's say patient has a STEMI or an infarction of the area of the myocardial muscle supplying the posterior medial papillary muscle. Now, papillary muscles are not growing. The chordae tendineae are not growing. They are like they are the structure which is going to stay the same size. So what happens in systole? This patient, if they develop a scar or they develop MI, they will have hypokinesia or akinesia or dyskinesia, right? So the motion in systole will be less. So in systole, all these structures are coming inside, but the scarred part and the papillary muscle and the chordae tendineae attached to that, they are not coming inside. So when all these parts come inside, the part of the mitral valve leaflet that is attached to those, they have a room to close. But the part of the anterior and posterior leaflet that is attached to this papillary muscle, which is infarcted, that is just standing still in time. So the part of that leaflet, the scallop of the leaf, it also stands still in time. It's not going to move when other things are moving. So you will have on the motion image, you will see that that part is restricted on one side, and on the other side there will be tethering or a typical tenting motion, which you will see. So this is what I'm talking about, the tenting motion. You see this anterior leaflet. If there is an infarction over here, then you will have this kind of typical tenting. I'm going to show you more images of that. This is typical tenting of the leaflet, which is seen. And because of that reason, because the posterior leaflet is restricted, you can get an eccentric MR. So this is a better example of that. You see the posterior leaflet is completely restricted. The EF is reduced. There is less thickening of the wall. So this is the ventricular MR. And the anterior leaflet, you see this kink here. So that is typical for a tethering of one leaflet and restriction of other leaflet, or just restriction of one leaflet without tethering. That is the diagnostic, or that is very important for a ventricular MR to be diagnosed. So now how to approach a patient with MR? It is not okay in the report just to write mild, moderate, severe MR. No, it is not okay. You don't give any information just by writing this mild, moderate, severe. Anyone can look at it and say it is mild, moderate, severe, but that is also not always the case. The way to write a report or way to approach a patient who has MR and to have your checkbox in your mind is to first look at the mechanism, which we already talked about, then look at the timing, when is the MR happening, and third is quantification. You need to quantify objectively how much is the MR. You cannot just say severe MR. You need to say severe MR with EROA of this, regurgitant fraction of this and regurgitant volume of this. So step one is mechanism. We already discussed about this. This is fibroelastic deficiency or Barlow's disease, where both the leaflets are prolapsing, and it is so severe that one of the leaflet has ruptured, especially the P2 with the chordae, which is ruptured up there. So this is a spectrum. The mitral valve prolapse is a spectrum. You can just have prolapse of one leaflet, or you can have Barlow's disease where there is bileaflet prolapse, or there can be progressively worsening prolapse in between. So it's a spectrum, just like an autism spectrum, and you can have patients various in that. The second is functional or ischemic MR, where there is typical characteristic which I showed you guys, and the third one could be perforation of the leaflet that can also lead to type 1 MR. So first of all, the first thing is to know the mechanism of why the MR is happening. So let's come to the next question. If the question doesn't pop up on the screen, just scroll down and you can have the question. The images will be much more clear on your screen. Which of the following Doppler signal correspond to severe mitral regurgitation? It will be much more clear on your phone screen. Is it 1, 2, or 3? Which of the Doppler signal is corresponding to, which do you think should correspond to severe MR? No? Okay, so 5 of you responded. Let's see. So 13% of you are saying 1, 13, 2, and most of you are saying type the third one. Okay, we'll come up to that now. So why is it important? Because, and next question at the same time, is this MR signal? Next question, swipe down if the question doesn't pop up. Is this, would you consider this, or is there any possibility this can be an MR signal? Yes or no? Okay, 50-50. It's like, all right. Okay, so first thing is the mechanism which we talked about. The second thing is timing. So you have to look at the velocity also. It was almost 6 meters per second in the first one. So there is no isovolumetric contraction phase. If there is the most common confusion which occurs with MR signal is the AS signal. The AS signal will have an isovolumetric contraction phase, and then it will start. But because this is a leaky valve, there is no isovolumetric contraction phase. As soon as the QRS complex starts, you will have a high velocity jet, because the ventricle, the left ventricle, which is the most powerful pump in the whole body, it's pumping. So you will have in most of the cases, I'm saying in most of the cases, you will have a high velocity jet, and it will start as soon as the QRS complex starts. Now, I said it starts in the early part of the systole, that is as soon as the QRS complex starts. But if the patient has a mitral valve prolapse, and if it is only mild mitral valve prolapse, you will have it at the end of the systole, that is the end systole. You will have an end systolic murmur, or you will have it only in the end part. And M mode is the best mode to define that. If the mitral valve prolapse becomes severe, then you can have a holosystolic murmur from that. And a restrictive or functional MR will always have, almost most of the time will have a holosystolic murmur, because it starts as soon as the systole starts, and it stays down the line. So timing is very much important. So let's come to the next question. So the answer for the second was yes, because the second question was for the mitral valve prolapse. That was the end systole. Let's come to the next question here. A 72-year-old male with chronic atrial fibrillation and hypertension goes for transthoracic echocardiogram for evaluation of dyspnea. So he is dyspneic, he has chronic atrial fibrillation. His MR is occupying less than 40% of the left atrial area visually, and these are the parameters you get. I'm going to give you a little bit more time to calculate this one. What do you think is the answer? What is the severity of MR? Is it mild, moderate, or severe? I'll give you a little bit more time to calculate this one. So it's atrial fibrillation, chronic atrial fibrillation. So most likely it has to be an atrial MR, which could be annular dilatation. Most likely a central jet is over there. You have an LVOT diameter and LVOT VTI, and you have a mitral inflow. So things are going in the ventricle and things are going out of the ventricle. So in normal situation, they should match, right? Let's continue the equation. Whatever goes in the ventricle from the atrium should go out through the aortic valve or LVOT. But so if you apply continuity equation on this question, the answer comes out to be 64 ml, which is severe MR. Let's see how many of you. Yeah, no. Very small. Okay. All right. So this was severe MR. So the very easy way to classify severe MR is 4, 5, 6, 7. The EROA of 4, regurgitant fraction of 0.4, 50%, regurgitant volume of 60 ml, and vena contracta of 7 millimeter. So 4, 5, 6, 7 is very easy way to remember. If it's severe, you should have EROA, that is effective orifice area, from which the MR is happening, of 0.4 centimeter square. Regurgitant fraction of 50%. 50% of the volume should go back during diastole. If 80 ml of blood is going into the ventricle, then 40 ml of blood should go back into the atrium. If the regurgitant volume itself is more than 60 ml, that is considered as severe, and the two-dimensional, if you look at the vena contracta, if it's more than 7 millimeter, is considered as severe. So I know it will be hard to remember.
So why that is important is because a lot of time we have this tendency to measure PISA, right? He's going to, I'm sure, talk some more about it. So let's say if you have a late systolic MR, look at the PISA. PISA may come out like, 0.4, sorry, that 1 centimeter diameter. But if it's a very late systolic, you will see the volume is not going to be 6. So does that patient need severe MR diagnosis? So it's also because at the end of the day, if it's a late systolic, there's not enough blood going. But because it's such an acceleration, the PISA may be high. But that does not mean that regurg volume is high.
Yeah.
So that's why it's important when you're documenting somebody for severe MR, you define mechanism, you define your supportive criteria, you define your EROA as well as volume.
Yeah.
What is it?
Yeah. So this is quantification, mild, moderate, and severe. And why is quantification important? 20 years ago, there were studies that when the patients were asymptomatic and the EROA is, I'll just give you one example of it. If the EROA was more than 0.4 centimeter, they had a really high mortality rate. Of course, at that time, there was nothing available. And almost 40% of the patients did not make it up to 5 years after that. So that's how the criteria of mild, moderate, severe came into practice. And then we had all the treatments which are available for that. So that is why because the mortality depends on how severe the MR is. Now you may not have all the criteria. You may have just 2 of the 4, or there are other criteria also. You need to have at least some. I'm going to talk to you about that. How many criteria you need to have. So one is PISA radius. This is the PISA radius. You have vena contracta. You can just visually see the patient and see whether it's mild, moderate, and severe MR. Anyone can easily say, oh, this is just mild MR, this is severe MR. The problem occurs when it's an eccentric MR or a wall-hugging MR, where you don't know whether it is severe or not. Because if you just look at the amount of volume that comes out of it, it's obviously much less than the amount of volume of MR you see in that. But that's not the case. There is something called as a Coanda effect, where because of eccentric MR, you will have an elliptical PISA, and it may not be just one side, it may be the whole wall. Imagine it in 3-dimensional. It is above the screen and behind the screen also. We are just taking one slice. So it will have a whole MR like that, not just one strip like this, but a whole strip like this going in there. That's the Coanda effect. And that's why whatever calculation you do of MR, the calculation of MR and the visual effect of this is wrong. This was asked in training exam, one of the question of eccentric MR, and the answer was continuity equation. So next question. So let's say if you have only 2 of the 4 criteria, but the patient has severe dyspnea, what are you going to do? For that comes the next question. Just answer this question on your phone. What phase of cardiac cycle corresponds to the blood flow backward in the pulmonary vein physiologically? What phase of cardiac cycle corresponds to blood flowing backward in the pulmonary vein? Is it in all phases? This is the pulmonary vein should get blood into the left atrium, but when does it go back? So ST to slightly after T. Some are saying P wave, some are saying QRS complex, but and no phase. And okay. So
Somewhere between P and T.
yeah. So this is the normal. This is the physiologically saying. So normally there is a during ventricular systole. S means the ventricular systole. Keep this in mind. The blood is going into the left atrium, but we are talking about ventricular systole. So during systole, the left atrium is empty. So more blood will go into the left atrium normally. And in diastole, in the early part of diastole, the valve opens and the blood flows from left atrium to left ventricle. So there is still room for more blood to come into the left atrium. So you will have a systolic wave and a diastolic wave, and only when the atria contracts, you will have some blood, a tinge of blood going back into the pulmonary vein because of the contraction. So the correct answer, it corresponds to the P wave. In patients with AFib, you will not have atrial reversal. If the MR is severe, the ventricle is filling in systole from the pulmonary vein and also from the ventricle. So there will be systolic blunting because less blood is coming into the left atrium from the pulmonary vein. And in severe cases, the MR can be so severe that there will be systolic flow reversal, that when the ventricle contracts, the blood not only goes into the left atrium, but it also goes into the pulmonary veins. So with that, let's come to the next question. This is a 62-year-old. This is going to summarize everything. This is a 62-year-old male with chronic ischemic cardiomyopathy. He has been non-compliant with medications and is diagnosed with a bedside echo in the clinic as moderate to severe MR. He started on GDMT, that is losartan, Jardiance. We started all at the same time. Why? Because he says, now I'm going to take the medications, and he says that, I cannot do my work, I cannot do anything, so I'm going to take the medication. He says, I'll take the medication. So we start him on GDMTs. And we're scheduling for TEE because it's a moderate to severe MR. We want to quantify and do all the exercise which we did right now. He comes 4 weeks later, and during the TEE, you say, oh, it's only mild MR. Why is the patient only having mild MR and not severe MR? And is the bedside echo wrong 4 weeks ago? Or did the GDMTs make it better? So out of all these factors which I wrote, which of them contributed the maximum in the last 4 weeks for the changing severity of MR? In the clinic, it was moderate to severe, and now it is mild. The only difference is we did the GDMT in him in 4 weeks. Okay, most of you are saying preload. Some of you are saying all of the above. Okay, all right. So, all right. So there are 4 components of forward flow. You need to understand this is a very reflex thing that happens. If you see a patient who comes with congestive heart failure from the ED, get admitted overnight in the CCU, in the morning you do a bedside, they do an echocardiogram, you diagnose a severe MR. You don't even know the mechanism of why MR is severe, but we just say it's severe MR. The patient has grade 3 renal lower extremities, daily peace on oxygen, sometimes on BiPAP, and then we order TE for the next day, expecting the patient will get a TE. If you do a TE in patient who is volume overloaded, or his blood pressure is 170, 180, it's going to be severe. It's a very dynamic thing. You need to not have the patient in congestion. You need to have room for the forward flow, so that you need to have a proper afterload. You need to have a blood pressure being normal. The diastolic blood pressure also should be actually normal, technically speaking, but systolic matters more than diastolic. You should not have the patient in volume overload state. You should not be patient having an AFib with a heart rate of 140 running down and you are diagnosing MR. MR will change depending on the other parameters, and that's why GDMT and treatment of allied things is much more important than doing a mitral clip or sending the patient for mitral valve repair. So this is very important. I'm going to quickly sweep through a few slides now. Role of CMR. CMR is not very much useful in garden variety of MR. The reason for that is, you can easily diagnose them by TE and by transthoracic echocardiography. There are some future perspective about replacement fibrosis where CMR is very important, but we'll talk to them if we have time at the end. And I told you about 3 things: mechanism, timing, and quantification. You must also understand that the consequences. You should also mention about the consequences. Understand that there are some consequences of MR also, which is severe. So need to keep that also in mind. Role of 3D. 3D will give us accurate quantification. Okay, now can someone tell me which one is normal and which one is abnormal in this? So this is looking from the atria over the valves. Which one is normal and which one is abnormal, Arvind?
First one is normal, second is
What is the abnormality in second one?
it's probably prolapse.
Prolapse of which leaflets?
P2, A2.
All A1, A2, A3, P1, P2, P3, almost like Barlow's disease, like bileaflet prolapse is there. Okay, all right. So this is where we come up with our criteria. So this is a very busy slide. I just want you all to focus on this part of the slide, which is ERR of 4, regurgitation fraction of more than 50, regurgitation volume more than 60, and a vena contractile of more than 7 millimeter. Also, I showed that the pizza radius, if you keep a Nyquist limit of 30 to 40, it should be more than 1 centimeter. Should have pulmonary systolic vein flow reversal, and possibly a central jet with more than 50% of the area. So if it looks bad, you have to say it's bad or not. And how do you say it's bad or not? By quantifying them, or by objective, data, which is this data. So I think everyone will remember 4, 5, 6, 7 for now. Once you know this, mild and moderate will fall in line after that. So now we have only 20 minutes. So I'm going to run through the management because this is most important part of it. Let's go through a case. There is no question here, but I just want your opinion on this one. This is a 94-year-old male, class 4 dyspnea. Blood pressure is 106/60. His heart rate is 74. So he's okay with that. He's a grade 3/6 holosystolic murmur, and he's a typical 94-year-old labs. And this is his echo. What is the diagnosis of what is the mechanism of MR? Can someone tell me? So this is looking from the atrial side. This is looking from the ventricular side. Okay, so this is top and this is bottom. Nicole, what do you think is the mechanism of MR? So do you see the MR being eccentric or central? Oh, come on. It stopped working, sorry. It was eccentric. It was going like this. It was going towards the anterior side, or it's a 4-chamber view, and it was going towards here. I don't know why it's not playing right now, but that always happens. Okay, you see this one?
Yeah.
And what do you see here in 3D? Of prolapse of P2. So what kind of classification is this? Is type 1, 2, 3? Quickly. 2, right? Type 2, excess motion. And is it primary or secondary? So primary, because of leaflets are involved. So primary type 2 MR. So what is the treatment for this? What do you think should we do for this patient in an ideal world? What should we do the first thing for this patient? It's a Okay, you optimize volume, and then what is the surgical approach? What do you want to do as a definitive management for this patient? Repair. Repair is the best thing you want to do for this patient. But because of his 94 years of age, the STS score became 18. So what are you going to do now? Clip. All right. It's easy to say clip right now because you have 15 years of data. Let's go back in time in 2011 and 12. If you were a cardiologist at that time, and if this patient would have come to you at that time, you had nothing to offer this patient. And then came a trial called as Everest 2 trial. We started putting mitral clip in patients with primary MR. And if you just look at the first figure, you will say the blue is the clip and the red is the surgery. You would say that, oh, this is a wrong trial, or this trial has failed badly. The mitral clip doesn't help in patients. Mitral clip is not useful for patient. Why? Because the composite of death, surgery, and reoperation was much higher in patients with mitral clip. So there was like, oh no, what's going on with this patient? This trial is wrong. We should not use mitral clip in primary MR patients, right? If you just look at the first figure, do you agree with me? Yeah. Well, you can say yes. If the data shows that mitral clip is worse outcome than surgery, but when you just subclassify it into freedom from death, there was no difference in death of patient whether they went for clip or whether they went for surgery. Okay, I'm good. Okay, that means that mitral clip was non-inferior to surgery for death. And then they did a landmark analysis, and they found that the major difference was from surgery or reoperation. And that was also, you see the dip, the biggest dip is in the first 6 months, and then it's almost a flat line. So that means there was something happened in the first 6 months that made the data to be skewed. And that's why they did a landmark analysis where they left all the data from the first 6 months, and they took the data only 6 months later, and they found there was no difference in composite outcome after that. So the conclusion they came with this study was that mitral clip is a new device. It's a new procedure. The structural cardiologists are not well versed in using it. This is 2011 to 14, 11 to 13. So this is like, people are not well versed in it. The clip also can improve with time, and maybe it's mostly the complications from the procedure that's leading all these issues. So that's why for type 1 for primary MR, mitral clip was approved. So which patients were included in mitral clip in Everest 1? The flail gap, if it was a flail, that flail gap had to be less than 10 millimeter. The width, which we can look at in short axis or in commissural view, it should be less than 15 millimeter. Why is that? Because old mitral clip, you can only clip both at the same time. So you cannot clip one anterior leaflet and then move the clip and clip the posterior leaflets. You can only clip both the leaflets at the same time. So you needed both the leaflets together. There should be hardly any calcium at the tip where the grasping area is, and the coaptation depth, which is the red, and the coaptation length should be more than 2 millimeters. The valves, wherever they were coapting, they should not be coapting like this. They should be coapting normally at some places like this, like 2 millimeters. They should not be just touching each other. So this was a very strict criteria. And as the time passed, people started getting better. The clips improved. Then you were able to clip only one arm and go to the other arm and clip the other leaflet. So it's not that this criteria didn't matter. The significance of this criteria came down. Of course, we still look at this criteria right now, but we can still do clip in patients who don't satisfy this criteria. So then in 2018 came a study where they found the feasibility of mitral clip or TEER in these patients. They found that an ideal patient would be the one who has A2P2 prolapse. We are talking about primary only, or flail. They should satisfy the Everest 2 criteria, and they should not have a residual mitral stenosis to begin with. So these patients have a very favorable outcome and go ahead and do a mitral clip in these patients. But if the patient has all leaflet prolapse and there is calcium involved in the grasping area and they have baseline stenosis, the chances of mitral clip being beneficial to this patient is less likely. So they came up with a spectrum from which patients will benefit and which patient will not benefit in 2018. And then comes our guidelines for primary mitral regurgitation, the 2020 ACC guidelines for primary mitral regurgitation, where they also follow the same steps as we discussed. First of all is the mechanism. They looked at the mechanism. It is primary MR. Then they quantified the MR. Is it mild, moderate, severe? So it's a severe MR. And if the patient has symptoms, go ahead and go for the repair. If repair is not possible, go for the clip. Very easy. You quantify MR as you first say it's primary, then quantify severe. If it's severe, if the patient has symptoms, go for surgery, that is repair or replacement, but mostly repair. And if not, surgery is prohibitive, go for surgery. The problems occurs when the patients don't have any symptoms, which you will find some patients. Usually they do, but there will be some patients who don't have symptoms. So how do you follow this patient? You follow this patient only on two criteria: the ejection fraction, which should be supranormal in a patient with MR, and an end systolic volume, which is more than 40, should be less than 4 centimeter. If it's more than 4 centimeter and the EF is less than 16, then you consider that this patient is going to have symptoms very soon. So just treat them right now before symptoms develop. But we all know how EF is. We can always say EF 55 to 65, 60 plus minus 5, 65 plus minus 5. So it was a very vague criteria. And end systolic volume, if you don't have good images on two-dimensional, we may not be able to have a good quality and systolic volume also. So we were all putting all our money in one basket, which only has two components in it. But we also know there are many other parameters of remodeling also. So so this was 2020 when this happened. So in 2022, the new study showed a magic number of 60 for LAVI. Even if the patient was in sinus or in atrial fibrillation, a LAVI more than 60 was associated with excess mortality from MR. So this was the study. And then they did a retrospective analysis of all the registry data of all the patients who undergone mitral valve surgery. And they found that LAVI of more than 60, pulmonary artery systolic pressure at rest, very important, of more than 50, AFib, and moderate to severe MR, they all have independently associated with increased mortality even after surgery. And if there is a combination of these factors, it's a help for them, because almost 30% of the patient die in 5 to 7 years. So that's a big number. So that's when came the new 2025, just 2 months ago, the ESC guidelines for treatment of primary severe MR, where they still follow the same thing. If we have symptoms, if you quantify as primary mechanism and severe MR by quantification, if the symptoms are there, you go for mitral valve repair preferably. And if repair is not possible, you go for TEER, that is mitral clip or Pascal clip, or whichever clip is there. Very straightforward. But if the patient has symptoms, you still look at the two important criteria, that is the ejection fraction and the systolic volume. But if that's not the case, then you look for 2 of 3 of the 4 parameters, that is AFib, SPEP, and LAVI, and concurrent TR. If 3 of the 4 are present, there still is class 1 indication to undergo repair. So asymptomatic patient with SPEP more than 50. This was also asked in training exam based on the previous study, that there was a question for that, and the treatment was repair, even the patient was asymptomatic. Or if only AFib or SPEP or LAVI is increased, if only one of the 4 criteria is present, then it's a class 2A indication to go undergo repair. So we should not have any of these criteria. Keep this in mind. For asymptomatic patient, there is no indication for mitral clip in these patients. For primary MR, asymptomatic, no mitral clip. If symptoms, repair. If no symptoms, look for certain criteria. If those criteria, some of them are present, then still it's repair. There is no criteria saying mitral clip in these patients for primary MR. So next question, a 60-year-old male, dyspnea on exertion, volume overload, past medical history of MI 9 years ago, PCI to RCA, and he has 2 months of bronchitis. He says, oh, I'm having bronchitis. My primary care is treating with prednisone and all these things. He has edema, orthopnea, PND, JVP is up, and these are his echo. Can someone tell me what is the diagnosis of this patient? He had PCI 9 years ago. He came in with 2 months of bronchitis. So first of all, we look at the ejection fraction. What is the ejection fraction of this patient? Is it low or normal? Low. And you see that posteriorly, is it moving well or not moving? And anterior, you see that tenting, typical tenting like this. So that has to be a regional wall motion, and that papillary muscle has to be affected. So this is a functional type 3B MR. Okay, you see an eccentric jet towards the restricted motion, but you also see in this patient there is severe TR also. The LV is dilated, and the RV is also dilated, and there is severe TR also in this patient, right? So what's the next step on this question?
First years typically collapse. It's going to be opposite side, the MR jet, and the restricted is going to be on ipsilateral side, just to get you some hint.
Okay. This is the last question, so quickly answer this question if you can. So what's the next step for this patient? Do you go for bile surgical? He was 60 or 62-year-old guy. What's the next step? Do you go for viability testing for that EF? Do you go for mitral clip? Do you go for mitral clip and tricuspid triclip? Come on, guys. So most of you are saying surgical, what's the next step? And some of you are saying viability testing, and some of you are saying medical therapy. Okay, so let's go back to the question. The patient has dyspnea on exertion volume overload status, and he is JVP is 10, and he has edema, orthopnea, PND. So the next step is medical therapy. You optimize them, and then go for, if you have said mitral clip, it was fine, it was correct. But if it was not, first, the next step is medical therapy. After medical therapy, the definitive step will be what? Surgical or mitral clip? What? Surgical mitral and tricuspid, or mitral clip or surgical mitral valve repair or tricuspid valve repair? Surgical? Okay, all right. It's for,
Wait,
imaging after you optimize.
even if still shows severe. So you optimize severe, what is the answer? Surgical. Okay, so keep this in mind. This is a restricted leaflet motion, and the problem is not in the leaflet. The problem is in the left ventricle. So what are you going to repair in the leaflet? Surgical mitral valve repair. There is no surgical mitral valve repair. It has to be mitral clip, and that's where comes the COAP trial. And when this trial came out in 2018, all the structural cardiologists jumped from their chair. Why? Because all this knowledge and the expertise of the mitral clip for primary MR, which they had, that gave a very positive study. Freedom, look at the graphs. They just separate. As soon as we put the mitral clip in these patients, the graphs separate in the beginning all the way in the control, versus control is GDMT only, and device is mitral clip plus GDMT. Okay, so the graph started separating in these patients. There was hardly any device-related complications, hardly any. And the mortality, even though it was slightly more in the device group initially, but if you finish the first phase, you will have a good difference in mortality also. So this was a very positive trial. There was another trial called as the MITRA FR trial, but there was a very questionable trial because the GDMT was not well done for this patient. So there, because of that, looking at these trials, this is the latest 2 months ago came out, 2025 guidelines for functional or secondary MR, where if you know the mechanism as functional MR and it is severe by quantification, and if you need to separate them by ventricular and atrial MR, you cannot just treat all functional at the same time. keep this in mind. If there are no symptoms, no need to follow any labs, no need to follow any AFib, no need to follow anything else. If the patient has severe MR, if it is functional, whether it's atrial or ventricular, if they don't have any symptoms, just follow them medically and do GDMTs and do the AFib treatment, ablation, whatever. No need to do anything else. But if the patient has symptoms, keep this in mind. Mitral clip is class 1 indication for this patient. Why? Because there is no way you can bring that scarred myocardium back. You need to prevent MR to prevent complications. So this is the new guidelines. TEER or mitral clip is the class 1 indication for a ventricular, that is the EF less than 50, the typical restricted motion and tenting motion of the leaflet in an ischemic cardiomyopathy with regional wall motion. That is class 1 indication. For atrial MR, there is no class 1 indication because people still don't know with definitive what to do for this patient. So if the patient has symptoms and if you diagnose this patient as atrial MR, then you can consider doing mitral valve surgery, specifically repair. If not, then class 2B is mitral clip. But to be honest, because it's annular dilatation, you need to make sure the AFib is treated. And most of these patients, you need to make sure that, AFib is optimized first. But for ventricular MR, mitral clip is class 1 indication. So let's go through one case very quickly. There are no more questions for this one. So this is a patient. What kind of MR is this? Can someone tell me? You see the EF, is the EF down or EF normal?
Down, yeah.
Little bit down. And you see the mitral valve, they are not coapting like this. If you see in too many echoes, they are coapting like this. So you expect the annulus to be dilated. Okay. So what did I do? All right. So you quantify the MR, you did all the things, you look at the EF was down, you looked at it in different views. You also see some regional wall motion in some of these patients, so it could be a combination of type 3 and type 1, but annular dilatation along with, type 3 MR also. So whatever, this patient was not a candidate for surgery or high risk patient, or it's somehow the patient ended up on mitral clip table. So where is TE useful? TE useful in several steps. Almost the entire process of mitral clip occurs under TE guidance, where in bicable view, this is the superior vena cava, this is the inferior vena cava. You puncture the septum as superior as possible and as posterior as possible so as to protect the aortic valve. That occurs under TE guidance. Once the structural cardiologist indents or make a nick in, not puncture it, but just make a tent in the septum, you need to have at least 4 centimeters of gap between the tented part and the annulus for the maneuverability of the mitral clip. And then under TE guidance, you pass the catheter from one side to the other side. In this patient, this was too much towards the lateral wall, so you anti-flex it, bring it in the middle. And then under 3D, we do it on commissural view here, but ideally it should be done under 3D. You need the arms to be towards anterior and posterior like this, not like this. And fluoroscopy will not show this thing. So you need the arms to be exactly aligned towards anterior and posterior for optimal effect. So 3D is better for that, but commissural view is also better, but usually the people do in 3D. And then in long axis, you deploy the arms, and you see the residual MR. Unfortunately, the patient which I got had still severe residual MR even after the mitral clip being placed. So this patient had to undergo a second clip also, but this is how it looks like, and you can do the entire thing in 3D. So treatment options, we have mitral clip, which looks like this. This is a Pascal clip or spacer, which has got a spacer in between, which helps in larger annular dilatations. In type 1, it is much more helpful than in type 3, but it's only restricted motion. If it's annular dilatation, Pascal is much more helpful. These are all surgical techniques. I just need to know where to send for repair or replacement, because surgeons are going to take care of it. But you should know the name. There is indirect annuloplasty. You can do it percutaneously, also repairing the chordae, or you can have a bioprosthetic valves, multiple of them. Just know that there are a lot of valves available, and there are some surgical techniques also available. So that technically finishes the lecture. I still have 3 more minutes. We talked about 2011 studies. We talked about 2020 ACC guidelines and what deficiency it had. We talked about 2025 guidelines. Let's talk about what's going to happen in 2029 ESC guidelines or 2026 ACC guidelines. Why? Because we are smarty pants. All right. So what's the latest in mitral valve? So there is something called a strain available in these patients where they studied like we do strain for the ventricle, we can do strain for the atria also. And you can see there is a P2 strain is much more, and we found that the more the strain in this patient, they have got a high probability of developing mitral valve prolapse and mitral MR down the line. So you can, in this patient, the TE probe, our machines are not going to work after 5 years because the guidelines are going to include this, and all our machines are going to be obsolete, FYI. But you can see, you can generate a 3D image of how a prolapse looks like in these patients. And studies have shown that especially in posterior leaflet and in total mitral valve, with progression of mitral valve prolapse and with MR, the amount of mitral valve strain increases. There is something called regional fibrosis for which only MRI is useful, and is useful in diagnosing early mitral valve prolapse, whether it will cause complications or not. And with more the mitral regurgitation, there is more replacement fibrosis, there is regional or replacement fibrosis in this particular area, and you can diagnose or worsening MR or predict the MR earlier than that also. And last but not the least, AI is taking over everything. So there is some AI related technologies which is available here, where you can play in like video game, like how when you put the mitral clip in a particular patient, how much would be the residual MR, where should you place the clip, exactly how much distance from the left commission, from the left end or the right end, what centimeter difference you have to put the clip on, so that you will have the minimal MR. You can just play as if you are playing a video game with the patient's data. So that's what's coming down the line, and that would make the outcomes of mitral clip much more helpful. And this is the terminal slide for this thing. By 2029, all the patients of mitral valve are going to be diagnosed with their severity, of course, but they're also going to be diagnosed based on the LAVI and the GLS. Keep this in mind. An ejection fraction of 60% relates to a GLS of 21. So you should have a supranormal GLS or at least more than 21 GLS. So GLS of 21 is considered normal in MR patient. It's not in guidelines yet, but it's going to come down the line. So a patient who has normal EF, but the GLS is less than 21, as 20 or 19, it's still not normal for these patients. And the patients will be classified into phenotype 1, 2, 3, 4, depending on the severity of MR, depending on the LAVI, and depending on the LV contractility, that is the GLS. And probably in the next 4 or 5 years, by the time we start practicing, this will be the new guidelines, and this will be coming into the picture, and this is how things are going to evolve. That was my last slide. Thank you. Right. Any questions? Any questions? All right.